Hello, everyone. I'm really happy to announce Professor Zhiyong Lu, who is a senior investigator at NIH. Today, he's going to talk to us about surviving the trust gap. Biometrical AI requires evidence-based generation. And just a few words about Professor Lu. He's leading a research in biomedical text image processing, AI, and machine learning. In addition, he is an adjunct professor of computer science at the University of Illinois Urbana-Champaign and associate editor of the Journal of American Medical Informatics Association. Dr. Lu is a highly cited researcher with over 400 publications, and his AI research has been deployed in real-world systems like PubMed and LitCovid, serving millions each day. So Dr. Lu's research has been frequently featured in major news outlets and recognized with numerous awards, including the NIH Director Award, the Clinical Center CEO Award, and the NLM Regents Award. Dr. Lu has been elected to the American College of Medical Informatics and the International Academy of Health Science Informatics. So without further ado, Dr. Lu, thanks a lot for accepting my invitation to talk to us, and the floor is yours.
Thank you. Thank you very much for the kind introduction and the opportunity to be here. So as introduced, I come to you from the National Library of Medicine, which is part of the NIH, where I lead a lab, about 20 people working on biomedical AI and machine learning. So using AI and machine learning, we work primarily on natural language processing, text mining, but also we do a little bit of medical image analysis as well. So the kind of data that we work with primarily are tens of millions of articles in the biomedical literature. That includes PubMed and PubMed Essential full-length articles. When access is provided, we also work in directly on patient data that includes free text, clinical notes, EHR data, as well as patient image data, especially in radiology and ophthalmology, where we have wonderful clinical collaborators on the NIH campus. So we worked on a wide variety of different tasks and projects. So for today, I'm going to be focusing on trustworthy AI. That's my main topic today. But before that, I want to talk to you a little bit of my background and how we get to trustworthy AI with our experience with biomedical literature analysis. So I'll start with a database called PubMed. Now, normally when I speak, I don't need to introduce PubMed to the audience of biomedical researchers. But for this audience, in case you're not familiar with PubMed, you can think of it as the digital library for all the papers in life sciences. And PubMed was created about 30 years ago now, in 1996, by the National Library of Medicine. And as of today, it hosts over 40 million articles, and we serve millions of users worldwide each day. They're doing about 3 million searches and 9 million page views. That compares nothing to Google traffic, but does make PubMed one of the top 3 or top 5 most used websites by the US federal government. So working at the National Library of Medicine at NIH, that actually provides us a unique opportunity to using our expertise of AI to improve PubMed. So on the left, as you can see, this is what PubMed looked like 10 years ago. And at that time, if we enter a query of 3 or 4 keywords, the only way that papers will be returned are by reverse time order, meaning that the newer paper will be returned first, followed by older papers. So about 10 years ago, I was asked by the leadership of NCBI to at least provide an alternative to the reverse time order, that we can make and move the more relevant papers to the top. So working with my former postdoc, Nicholas Fiorini, we worked out a machine learning algorithm, or learning to rank algorithm in particular, that we can incorporate a wide range of different ranking factors that we can push the more relevant papers to the top. So this is later called the best match. This is also the algorithm that is used in PubMed today as a default search order. Along with best match relevant search, we also made a lot of different changes along the way. And when we first started the project, we called this demo website PubMed Labs. Now, obviously, back in 2017, 2018. Now, as you would know, that this is now officially the new PubMed. So as much as I love PubMed, we also created a separate literature search system called LitCovid during the recent pandemic. And I'll tell you why we did that. Because at the very beginning of the pandemic, it was very critical, I would say, that for the community, including the physicians, including the researchers and members of the general public, to understand this new disease. However, when people are looking for papers in PubMed, they can't find a comprehensive list of those papers because guess what? The COVID term was not coined or used consistently in the papers until summer 2020. So all the papers that describe COVID before summer 2020 used a wide variety of different descriptions. So it was very challenging for a user to search PubMed to look for those relevant papers. Therefore, looking at that motivated us to develop this specialized literature search system called LitCovid. And we did that very early on. We had this idea in late January 2020, and then by the end of the February, we have this system up running. And over the years, this system has served a lot of users worldwide. As you can see, some of the, in my experience, there are very few people actually giving us input or feedback, but for LitCovid, we have received quite a few of those comments from our users. So both PubMed and LitCovid are literature search systems. Primarily, their goal is to helping users to find relevant papers to read. But I'll argue that today, the problem is perhaps not for scientists finding relevant papers. It's the opposite. We have too many papers that we are unable to read given a query of 3 to 4 keywords. We are often returned with hundreds of papers, thousands of papers, or even more. And there's no way that for individual researcher to go through that long list of papers and then to make connections of different studies. So the million-dollar question is, can we actually teach computers to read just like human scientists? And then they can connect these papers and then to drive new discovery or generate new hypotheses. So towards that goal, we did some baby steps. We started to teach computers to recognize important concepts in biomedical studies and what are the relationship between these concepts. So we created separately 2 research systems called PubTater and LIVAR. So I often joke that PubTater is sort of PubMed on steroid. And the reason I say that is because it really has 2 separate advantages over the existing PubMed system. One is that PubMed only hosts a title and abstract. So if you need to looking for full-length articles, you have to go to a separate database called PubMed Central, okay? But in PubTater, we provide a unified platform that you can search both titles and abstract and full-length articles. So we combine them 2 in 1. Secondly, and I think more importantly, is that instead of just showing a raw title and abstract, we provide semantic annotations. As you can see on the right side is example of a PubMed article where we have highlighted genes, diseases, drugs, and chemicals in different colors. And this is all annotated completely by AI algorithm that we have developed in the past. Okay, now, are they 100% accurate? They're not, but they are accurate enough, I think, matching human performance. Because if you ask 2 biologists to annotate the same article with gene names, I can guarantee you they, first of all, not going to do any better than AI. Second of all, they're not going to agree with each other most of the time. Okay. Beyond PubTater, we also developed a separate system called LIVAR, which is specifically for genotype-phenotype relationship. And the difference is, and the reason we have this separate database or separate system is because not only we go title and abstract, full-length articles, for mutations, we actually go even into the supplementary materials. So normally, we are reluctant actually to extract information from supplementary materials because that type of data is very noisy. People tend to put everything, different files, different formats into that supplemental material category. So it is very hard or challenging to get that right. But our users has repeatedly sort of asked us, Dr. Lu, you have to, for mutations, you have to go to supplementary materials because most of the information is only available there. And our users are absolutely right. So once we have done that, we actually find that the content of mutations has increased multifold because of access to supplementary materials. But for other entity types like genes and like diseases, we still stay on the full text articles. So taken together, these research systems actually have been used very widely from users all over the world. This is something that I'm quite proud of because we created, unlike PubMed, which started 30 years ago, even before I joined NLM, for PubTator and LitCovid, these are the systems that we built from scratch. And as you can see, we have had over 1.6 billion users from users either using our system through web visits or APIs. There are a wide variety of ways they use these systems. I'll say that some of the exact example applications, including using PubTator to speed up manual curation, literature curation, or to using PubTator to create biomedical knowledge graphs. We are continuing the line of research in this direction, but I'll also say that our research direction has somewhat affected, disrupted by ChatGPT, the launch of ChatGPT in November 2022, just like everybody else, okay? And I can speak for that because prior to ChatGPT, I would be the only person in my household knowing about AI. But now my wife, who's not a scientist, using AI for her work, and I have constantly also taught into my kids to stay with chatbot while they're doing their homework. Okay, so but I think AI is sort of redefined in a way that this is something not only impact researchers or scientists, but also something that everybody, the general public, is using them in their daily lives. Speaking of AI large language model in healthcare or in biomedicine, there are just constantly news stories about these disruptive transformative technology, but they are sort of in two different camps. On the top are the ones that talking about how great this technology is, what's its potential to transform and benefit healthcare. But increasingly, I think in recent reports, there are news about the potential risks and issues with using these large language models or this new technology in healthcare. So in my own research program, we actually looking at both issues. So some of the signature project that we have completed in the last 2 years, including utilizing AI, for example, for the first time, large language models to matching patients to clinical trials. So this is a big deal because this is really the basis for evidence-based medicine. And clinical trials also play an important role for new drug discovery. Obviously, everybody cares about that. We have also used AI agents to improve accuracy, to reduce, minimize issue of hallucination in gene set analysis, a very common analysis in bioinformatics data analysis for drug discovery. So these are sort of examples on the left are examples where we take advantage of this new technology for important tasks in biomedicine. But on the right side is our other emphasis or focus of our research, which is looking at potential risks and problems. And in that particular study we published in 2024, we look at the GPT-4V, which was just launched, first multimodal large language models, how it performed on visual question answering. Even though we find it performed extremely well, meeting human expert performance, the problem we find is that in 1/3 of its answers, even its answer is correct, there are some hidden flaws in its reasoning or its ability to understand the medical image. So the takeaway is we really can't just trust its answer completely, even though it may be correct. Like I say, we've done quite a bit of research in that regard. We're not going to, but those are not the topic of today, but rather the ones that I think the reason I was invited is because the organizers noticed our most recent research called MEDB1, but I also like to take the opportunity to talk to you about even newer study that we just wrapped up called the Deeper Med today. So as I mentioned, we are at the National Lab of Medicine. So the first study actually we did with the large language model was this short essay that we published in spring 2023. And we were thinking about, now that we have ChatGPT, instead of looking at using PubMed to answer questions or looking at finding the references or finding the relevant papers to read, would people just using ChatGPT to ask questions directly and without having to go through that long process of literature finding and literature reading? And indeed, when we did that study or exercise back in now 3 years ago, we find that AI can do that, but then AI fabricate the evidence or fabricate the citations completely. Okay. Now, this is something everybody knows as hallucination these days, and this has improved, I'll say, by the more recent version of AI or large language models. ChatGPT 5.5, Gemini 3 does a much better job, but they are not able to address that problem completely. So just early last month, there are back-to-back news reports about this issue. One talking about hallucinated citations because AI is now used by authors in writing their papers. A week later, a news report that scientists invented a fake disease, but AI told people it was real. So clearly, this is not an issue that has completely addressed by the current technology. So going back to this question answering, so when a user asks this question and then AI generates a report or generates a citation or reference, then the key question is, can we actually verify to see whether this reference actually supports the answer? So this is something known as evidence verification or evidence attribution. And then I think that some of the colleagues in this call has also worked on this particular performance. So there are ways you can do this. Traditionally, there are transformer BERT-based classifiers that you can use to do this verification process. But I think they are limited in a way that, one, they're unable to provide any explanation. They cannot explain why a source is supporting or refuting a particular claim, even though they may classify that correctly. And also, these classifiers are not zero-shot, do not work in a zero-shot fashion. They require a massive amount of in-distribution training data. So their use is somewhat limited. On the other hand, you can actually just using a frontier large language model to do this. And they can do actually a pretty good job, in my opinion. However, there's an issue of privacy. You often using a proprietary model through their APIs. Do you really want your own dialogue to be used, to be shown, revealed by these AI models? And I think the bigger problem is this is not really feasible for scalable, large-scale evaluation or large-scale verification. We did a sort of a calculation ourselves that if there are about 150 million medical chats each day, that can translate to about 1 billion citation statements. Okay, so 1 billion chances, opportunities to do the verification. And if you're using a frontier model like GPT-5, that would cost more than $500,000. On the other hand, if we're using a small large language model like 3B model, that would only cost 1%, less than about $5,000. So that was basically the motivation of this METV1 study that we just recently completed and led by a current postdoc, Dr. Chao Jin, in my group. He also kindly provided some of the slides for this part of the presentation. So the goal is very clear. We want to, using a small language model for the evidence attribution verification task. And we want this small language model can perform as well as the large frontier models. And same time, we want to demonstrate some of the real world applications of this small language model. So the key then is, how do you train this small language model to be performing as good as these large language models, 70 billion models? So the way we do that is through creating training data for METV1. And we did that at this slide show you exactly how we did that. So we take 1 million articles from PubMed. As I mentioned, the PubMed has 40 million, so we just take 1 million. And then for each of the articles, we would suggest a supported claim and a refuted claim, okay? And then for each claim, in each category, we would, using a retriever, to retrieve 10 most related source articles. Now, we used our own tool called MedCPT, which remains to be actually state-of-the-art tools, but you can using other dense retriever or BM25 classic retriever, whatever works for you. But essentially, we have each claim, we have 10 articles associated. So that's a 10 million article claim pairs, okay, in both groups. And then for each of these pairs, we would go through an initial screening using a GPT-4o mini. And in this step, basically, we would clean up and filter out some of the easy claims and some of the bad claims. Bad claims meaning they're not really useful for the downstream training process. Easy claims meaning that all 10 articles tend to favor or say agree with that claim. So it's too easy. There's nothing really interesting to be used for training purposes. And after that step, then we remain about 300K controversial claims in the supported claim category and 234K in the refuted category. And then we send them to 5 different large language frontier models. And these 5 large language models will vote to say, putting the given a claim and a source article, we would put into one of the 5 labels or classes. These are strong agreement, partial agreement, neutral, partial contradiction, and a strong contradiction. Okay. So after that, only if the 5 sort of LLM judges agree with each other, then we would using that as the final label for that claim article pair. Okay. So in the end, we have about 1.5 claim article pairs that we can use for training purposes. And they scattered across 5 different classes, from strong agreement to strong contradiction. So I show you example, so that will make you more clear what I'm talking about here. So given an article which has the PMID 9035431, so that's our seed article. And from that article, we can generate a synthetic claim, okay? And in this claim, it basically says a drug is more effective than another drug. A drug is more effective than the E drug. And then using that claim, we can use MedCPT to retrieve 10 most relevant papers. One of those papers is PMID 249-35303. Clearly, it says the different, it says that one drug is actually the opposite of that. So given that claim and source article pair, we send that to the 5 different large language model for voting as a judge. And then they come back with their consensus. And in this case, the consensus is this source article would strongly contradict or refute the original synthetic claim. And so this is one instance of our 1.5 million cases in our training data. So as you can see, The 5 categories have 23% strong agreement, 15% partial agreement, 36 neutral, and then another 25 across the partial contradiction and the strong contradiction. Now, how do we know that a panel of large language model judges are doing a good job? Well, the only way we know that is we have to have some reference standards. So what we did is that we randomly selected 100 claim article pairs in our training data, and then we had 3 human experts, annotators, manually annotated them independently first, and then we have them meet together and come up with a consensus. Okay, so for the 100 claim article pairs, we have so-called ground truth or reference standards. And then we compared actually their individual annotation to the final ground truth. As you can see in this confusion table down below, the automatic generated synthetic data or synthetic label is actually better than any of the 3 individuals when they did the annotation separately. So this is a way that we making us confident that the synthetic data or using the large language model as a judge, actually a panel of them actually works in this case. So once we have this data set, then we started doing a training process. We started with 2 backbone models. One is Llama 3.2.3b model, and then the other one is Qwen 2.53b. We did 2 steps of training, first through supervised fine-tuning. That is, we used instruction and claimant article pairs, and then as the input, and then generating the rationale and the label as the output for the model. And we go through that 10 epochs, and that took about 1 month on 8 NVIDIA H200 GPUs. After that first step, we also did a reinforcement learning that to further fine-tune and further improve the performance. And in that case, it took about 1 week on the same computer. Okay, and we give a reward using what's the ground truth label and what's the predicted agreement. So once we have trained these 2 3B variants, we call that the 3B METV1 L model and METV1 Q model, and we can apply them to a wide variety of different tasks because we can certainly apply them directly to the claim verification tasks, but we can also apply them to related tasks like Boolean QA. Basically, we turn the question into the claim, and then the answer, the document to supporting the answer as the source article. So because METV1 works in a zero-shot fashion, we can directly actually apply the model to these different tasks. And we've selected 5 different data sets for benchmarking purposes. We believe these represent a wide variety of different tasks, also the different quality and different data sets that for benchmarking purposes. So here are some of the results that we like to show you. As you can see on the 5 different data sets, again, like I say, some of them are different tasks per se, but we all turn them into a verification task in this particular case. So on average, which is the figure on the bottom right, we have about 60%, 70% accuracy for the METV1 after fine-tuning, okay? Obviously, if we just using the 3B model from off the shelf, their performance is very far from the frontier models. But after training, their performance is just as good as these 5 different frontier models, GPT-5, GPT-4o, or Llama 70B. Okay, so the other way to look at this, and this performance is actually very consistent across all 5 different benchmarks. And the other way to look at this is to look at the density, which is calculated by performance over model size. So in computer science, it is estimated that the frontier models were doubling the density every 3 to 4 months. But if we look at the way we did that for fine-tuning a small language model, the density is actually 20 times higher compared to the original model or compared to the larger frontier models. So, but you may ask, yes, you increased performance to 70%, but they're not perfect or they're not in the range near 90%. Why is that? So we looked into this, and we believe the problem isn't really about the performance of these models. In fact, we believe there are problems or issues with the data sets. So when we looked at this in an error analysis, we find there are actually issues in the data set that we consider data set noise. So in a way, the performance is somewhat underestimated in our opinion. So once we have this model, then what we could do is we apply this to a wide variety of different real-world tasks. And one of the tasks that mentioned or included in the paper is that we're looking at clinical guidelines. These are potentially important documents available in PubMed that are talking about clinical treatment or disease management. Okay, so we took about 6,000 of them, and then we generated a statement and article pairs. So from the 6,000 clinical guidelines, we can generate pairs of statement and article pairs. And then basically these 57K pairs go through MEDV1 very quickly, and then we can generate to see whether the article actually supporting, refuting these claims. And what we find is about 1.6 such pairs have partial contradiction, and 1.1 is strong contradiction. This is not something that we would expect, because we were thinking that clinical guidelines are really of high quality and every article cited should be supporting the statement rather than refuting or contradict. So we manually took about 50 from each partial and strong categories, and then we did a manual assessment. As you can see, we indeed validated some of the misattributions are indeed problematic, especially in different categories, including in the treatment, including the risk, including talking about diagnostics and prognostics. So here is just one quick example of such a problematic statement or reference. So in this particular article, there is a statement talking about in this particular trial, there's a 32% reduction in the risk of VTE, and cited is Article 9. But if we look at using this Article 9, what we find that this Article 9 is actually talking about the incidence of reduction only between 1.5% to 4%. So it's not really supporting the 32% in the author statement. So this is very problematic, and this is automatically detected by MEDV1. So to conclude this first part of the study, in summary, I think the beauty of MEDV1 is this is really a lightweight language model that we can use for large-scale, scalable attribution verification task without having to worry about the cost, without having to worry about the efficiency. We were able to do that because we have this data set that we created that can be utilized to boost the performance through additional fine-tuning and reinforcement learning part. Now, obviously, this is also limited with that we are right now, when we look at the source article to do this verification task, we're primarily focusing on title and abstract. We're not using the full-length articles, the content from the body of the article for this verification task. I think one reason is because it's more complicated. The other reason is more practical, that not all articles we have access to the full-length, the body of the full-length articles. So now let me switch gear and talk about our second most recently finished project related to AI agents, which is something that I think is already impacting the scientific community in many ways. There are papers talking about using AI scientists or co-scientists working on research project from the very beginning to the very end, with or without any human involvement. Science has been impacted by AI in many different ways. I think for sure we've seen more and more papers, and in one way we are also contributing to this problem. You probably all, like myself, like you, we probably write papers and submit into AI conferences. and there are, for top AI conference, there are tens of thousands of submissions each cycle. In PubMed, I used to say that we only have 1 million articles each year, new articles. But then I did this not too long ago, just 4 weeks ago, I found that in 2025, the growth is now about close to 2 million articles. So that's huge. Also, a recent article by In Nature shows that AI is not only impact the size of the scientific literature, but also the different studies. It seems to be contract the science focus. So the question is, in the MEDV1, we are trying to verify the citations that are supporting or refuting the output or claims statement generated by AI. But the better issue is, can AI basically generate free of hallucination? Okay, so in medicine, I don't think it's there yet. So here is a concrete example where I ask AI the question, among patients diagnosed with herpes zoster, what percentage develop herpes zoster ophthalmicus? So basically, develop shingles, what fraction of the patients also affected in their eyes? And I tested not too long ago with the most recent AI models like Gemini 3, GPT 5.2, and Cloud Sonnet 4.6. And all these three models give me 10 to 25%. And I'm not a physician, I'm not an ophthalmologist. I would probably just trust that number. But when I presented this to my colleagues at National Eye Institute, their first impression is that's probably not correct. It should be a number less than 10%. And they are definitely right. But the reason AI models, all three models, pick up this 10 to 20 to 25% is because they relied on articles that were retrieved that are highlighted in yellow. Okay, so for example, there's a review article published in 2008, which cites a study published in 1982. And in that 1982 study, yes, indeed, it was confirmed 15 to 25%. Okay, but then this 2008 review article gets cited by another article in 2023 and by other articles. So all these yellow articles highlighted in yellow here, they are reporting the 10 to 25%. Okay, even though the truth or the more recent, stronger study back in 2019 that are highlighted in green, about 7 or 8%, they never actually get a chance to be surfaced above the water, sort of picked up by these AI agents or large language models. So in a way, in the scientific literature, so these are not hallucination per se, but the bigger problem is that these AI models are relying on what the author state, relying on something sort of common and prevalent in the literature without having a separate function of evidence assessment or evidence appraisal. What really needs to happen, in my opinion, we call it evidence-based generation, an idea we copy or we borrow from evidence-based medicine. AI needs to do a comprehensive and deep search first, but then what's really important is they need to assess the quality of each retrieved study. You know, is this a review article? Is this a primary study? And is this a RCT versus an observational study? So on and so forth, before they actually synthesize and generating the answer. So apply these simple principles in an actually straightforward way. We developed a system we call DeeperMed, stands for Deep Evidence-Based Research for Medicine. This is led by another postdoc in my lab, Dr. Wang. So in Dr. Wang's design, we use AI agents. You know, we're still taking advantage of the latest and greatest AI models. We use them as an agent, and in 3 different stages, in multiple different places. We use them to understand the question and to generate a plan of sub-questions, decompose that into sub-questions. We use them also in this second stage in the middle called agentic collaboration. We use the large language model to retrieve articles through knowledge graph and from trusted resources like PubMed, like clinicaltrial.gov. But before we ask AI agents to generate the answer, we actually ask AI agents also perform evidence screening. Okay, so this is very unique and very different from any other system that we have seen or we have experienced so far. Now, to evaluate such a system, we looked up all the public data sets, benchmarks that we can find in the public domain, but we didn't find something that really relevant for our purposes. For one, most of the open domain question answering data sets are already sort of in the public domain for a while, so that AI, they probably has already been also utilized, even though not for sure, by these AI models in their model training process. But perhaps more critical, the question is, when we look at these questions, they cannot really represent the real world complex research questions in biomedical research. So what we end up to do, because we're at NIH and because we have colleagues also outside, we have access to a panel of 11 domain experts. These are working PhDs and MDs at NIH or outside, who actually helped us come up with real world questions in their research, in their clinical care. So we have these 100 questions that represent both the bench side basic research all the way to clinical research and patient care. And these, as you can see on the left table or figure, they also represent a wide variety of different disease subspecialties. So just give you a flavor of the kind of question we have, and these are the two questions in the oncology cancer domain. So we also want to compare DeeperMed with existing tools, and maybe foolishly we picked up ones that are best models, as we can see, best production models or leading production models. The reason we select them, because these days these models are perhaps already being utilized or already being used by the scientists and by the clinician in their daily lives, okay, for answering their questions. So in the end, we selected OpenAI Deep Research variant. We selected Google AI mode Deep Search, and then Open Evidence. For those who are not less familiar, this is a platform that's very popular among the medical community. So for each of the 100 questions, we run our question through 4 different systems, our own DeeperMed, and then 3 other systems. And then we return the 4 results to the domain expert and ask them blindly assess the quality and then compare the quality of their answers among 5 different dimensions. So we ask them to compare answers in terms of accuracy. We'll ask them to compare and evaluate the quality of the reasoning, as well as the reference, whether or not the reference are real or fake, or as well as whether the reference actually supporting their answers. We're also ask them to see whether the answers contain information that are previously not known to the people who asked the question, as well as we ask them how comprehensive the answer is. So as you can see in this slide, compared to the 3 other existing leading platforms, DeeperMed has outperformed all of them consistently across all 5 dimensions. So now going back to the question that we used as the teaser, as you can see here, yes, DeeperMed also reports or answers 10 to 25%, because I think that number is just so common and so prevalent in the scientific literature. But at the same time, our systems is able to actually picking up a variety of more recent studies talking about 8%, 9% distribution. So as I mentioned, I think the 2 key components of DeeperMed, one is we utilized knowledge graph, domain knowledge for grounding purposes to expand search scope. Secondly, we used evidence appraisal as part of the evaluation screening process. In both cases, as you can see in this ablation study, that with or without knowledge graph or with or without appraisal, we are able to actually improve the performance. Now, we can't do this with the human evaluation. That's just very costly. So we used other public data sets for this particular studies. So in summary about DeeperMed, I think we certainly can guarantee actually that DeeperMed is free of hallucination in terms of generating citations, because we don't ask AI to generate citations. We're using AI only to retrieve relevant citations from trusted resources. Here, nothing is everything. I think even with a little bit of hallucination, you're going to quickly lose the trust from the end users. Now, obviously, we do this also very differently from these commercial platforms that we have a manuscript clearly demonstrate how we do this whole entire pipeline, and we also show that we perform better. Apparently, this is a deeper research system, so you don't expect the AI can generate the answer or DeeperMed can give you the answer right away. This takes minutes for complex questions. But this performance or this latency is also consistent, because if you're using OpenAI deeper research system, they do not generate the answer like chatbot right away as well. In the future, we like to do additional testing, and we also think that contextual knowledge graph would help further improve the performance. So what I like to say that, as you can see, the study of MEDV1 or the study of PubMed or PubTater, they all sort of, in a way, to talk about transforming unstructured text and large data sets into structured useful knowledge. Either they are helping the scientists to accelerate their discovery process, or they aimed to help physicians for better clinical decision support, better clinical decision making, and improved care. So we want to continue this line of research, but also I think to do this, we also have to incorporate additional data modalities. I talked at the very beginning, if you paid attention, that in my lab, a part of my lab also does medical image analysis. But all the projects, DeeperMed, MEDV1, PubTater, PubMed, or text-centric. So let me quickly show you some examples of medical image analysis that we have done in my lab. So this is working for age-related macular degeneration, a prevalent disease for blindness in this country. By estimate, it's going to impact actually 50 million people in the United States. So, but unfortunately, there's no cure for AMD. So the only thing we know is that we can give a high-dose zinc vitamin to slow down the progression, but this high-dose zinc vitamin should not be given to a healthy person or people actually with an early stage disease. It's only should be prescribed to the intermediate stage. So clinically, from a clinical perspective, care perspective, it's very important for physicians to be able to diagnose the severity level accurately, and also to do a good prognostic risk prediction. But this is very hard given the very short encounter, at least in the US. So what we end up doing is that we take the retinal scan images, and then we can use deep learning to automatically diagnose the disease as well as to predict the risk to the level that as good as human ophthalmologists and retinal specialists, in many cases actually exceeding their performance. We started a project 10 years ago, and we initially worked on AMD, but later we also worked on cataract and even a heart attack based on retinal scans. We still, some of the trainees worked on this project has moved on, but we continue working in this area in ophthalmology, medical image analysis. We also worked with our colleagues, radiologists at the clinical center, where 10 years ago, we actually released the first very large chest X-ray data sets, includes over 100,000 X-rays with the labels that we text mined from radiology reports. This really moved the field forward, because up until that time, there was very limited large-scale data set that is available for deep learning purposes. Obviously, because of our interest in both text and image, it's very natural for us to work on text, image, vision language models. So recently, early this year, we participated in a study where you can actually upload a 3D CT volume into a platform where then you can have a meaningful dialogue with the AI chatbot asking questions. CT chat is nice. It's really moved the field forward. But I'll say that just like this, it's not ready to make a difference, because you need to finish the last mile, which is really need to employ or deploy implement such a AI methods into actual clinical workflow. And this is something that we've been trying to do for all the AI algorithm that we develop. We're not always successful, but I do want to show you one successful case that we did with our radiologist at NIH, that we were able to deploy the 3 homegrown AI segmentation tools into the PACS system within the NIH Clinical Center. And the goal is that not only for people knowing about AI, but actually more importantly, for clinicians who do not know anything about AI, they can use these tools as part of their daily workflow for understanding and better treating patients, especially in the chronic liver and metabolic diseases in this particular case. So I'll stop here, and I'll say that even though I'm really presenting on behalf of a wonderful group, as well as our collaborators both within and outside of NIH. So I think we have around 5 minutes for questions. I'll be happy to take. Otherwise, feel free to email me. You have my email on this slide. Thank you very much.